Um, Welcome everyone. Good evening, and welcome with us in our special webinar using evidence-based practice to improve clinical decision making with a very well-recognized speaker, Madeleine Flanagan. So we all know Madeleine Flanagan. She has been as a wound care specialist for over 30 years now in a variety of hospitals and community settings. She was responsible for the development of the first undergraduate program in wound management in the UK. And she's now currently the program director of the Master in Skin Integrity and Dermatology in the University of Hertfordshire. So welcome, Madeleine. The mic is yours.
Okay.
We can start.
All right, thank you very much for your kind introduction. And good evening to everybody online. Could we have the next slide? Okay, I'd just like to say how impressed I am that so many people have decided to join us this evening. I know it's quite late where many of you are, and you know your enthusiasm is fantastic, especially about a subject, evidence-based practice in clinical decision making, because it can be quite dry. So what I aim to do tonight is hopefully make that a bit more interesting for you and try and infuse you with my passion for evidence-based practice to underpin best practice in clinical management. Now, as you heard from the introduction, and I know many of you know me because I've looked at the participant list and I can see many current students of mine and many previous students of mine. And welcome to you all. And if we've not met before, I hope to meet you all in person when we've got through this terrible pandemic and situation that we're currently in. So welcome to everybody. This is the University of Hertfordshire, where I have been working as an academic for the last 20 years. So I only have a limited clinical caseload at the moment. I input into a complex wound clinic in my local hospital, but most of my time I'm working in a postgraduate medical school running a master's degree in skin integrity and wound management and dermatology. So I think I'm sort of well placed to talk to you about the difficulties in understanding that people do have, both doctors, nurses, all types of health professionals, I think do struggle with some of the research aspects that underpin evidence-based practice. So I'm going to try this evening to explain some of those concepts to you, and you can see in the top hand left of the screen a photograph of me from 1991 on the cover of Nursing Times, when for the very first time wound management sort of got into mainstream, and I was really at the right place at the right time. Now, what was interesting in 1991 is there was very little evidence at all about wound healing. We knew a little bit about antiseptics and we knew a little bit about moist wound healing, but really in the 30 odd years since then, the whole evidence-based philosophy has grown, and it can be quite confusing. There's a lot of information on the internet, and I'm going to encourage you to look carefully at the evidence so that you don't spend lots of wasted time. You're all very busy practitioners, and we've got to make sense of the best literature that we can. So that's really what I'm hoping to do in this session. So we'll move on. So critical appraisal, as soon as I start to talk to people about critical appraisal, people get sort of nervous and worried that they haven't got a research background. Now, for me, critical appraisal is about clinical skills. And when you're reading a study, you need to ask yourself the question, what sense does that make to me? How does that relate to my clinical practice, and how does it relate to my patients? So I want you to be more confident about that. So you don't need a PhD in research methodology before you start to think about critically appraising the literature. You need to know what's good, solid evidence and what is weak evidence. And you need to not worry too much about the weak evidence. We haven't got time to read everything. So I'm going to try and outline to you what are the better bits of evidence to look at. So we'll move on. So you've seen this slide before, and I'm not going to go into any great detail here, but evidence-based practice as a phenomena has been around for 20, 30 years. But I think the important thing to remember is it's about not just the evidence. So it's not about the research findings themselves. It's about taking those research findings, and it's about you thinking about your own clinical practice and your own patients. And it's about you making a clinical decision about the relevance and the validity of those research findings. So just because something's published in London or in New York doesn't mean necessarily that it'll relate to you. What you need to do is look at the entry criteria to a study to make sure whether the patients that are being investigated or studied are actually similar to your particular patients that you're looking after. So it's about the research, it's about the evidence, and it's about your clinical judgment. So what's the point in evidence-based treatment? Well, of course, it's difficult keeping up to date these days. A new treatment might be more effective. It might be have less side effects. It might be more cost effective. Or from our point of view as clinicians, it might be much easier to use. So there's a whole variety of reasons why we might want to change our practice and think about a new way of doing things. And I think all of us, however experienced we are, we've always got to say, why do I do it that way? Is there a better way? I don't think we should change practice just because we've read something or just because we've been to a conference. We need to make our own clinical decisions, and we need to make sure that they're based on the right type of evidence. So that's what we're going to focus in on this evening. So and you can see here on this slide, I think clinically, this is what evidence-based practice is about. And the first one, the most important one, is if we know what is effective treatment, if we know the outcomes are better with a particular treatment, then we as clinicians have a responsibility to use that treatment as early as possible and get that treatment, targeted treatment, onto the right patients. It doesn't mean reading about something, deciding to use it because you've read about it, and then using it for every single type of patient that you have. So you need to look at the study, look at the parameters of the study, and what are the clinical recommendations for that study. And you need to apply that to your own patients. Obviously, patients want their wounds to heal. So if we can help them get their wounds healed quicker, we're going to see improved quality of life for patients. We're going to see less complications. And our managers are going to be pleased about that because we're going to have lower healthcare costs. And that's good for everybody. So evidence-based practice is just as relevant for the patients as it is for anybody else. So what is the strength of evidence in wound care? These are the types of wounds we're very familiar with, and we won't find a study to prove everything that we need to do. Sometimes people say to me, why aren't there more studies on fungating wounds? Or, you know, we have lots of studies on diabetic foot ulceration, lots of studies on venous leg ulceration, but less studies on surgical dehisced wounds or large sacral pressure sores. And that's partially because of funding. It's partially because research is very difficult to do. Research is very time-consuming, clinical research, and it's hugely expensive. So we've got to be realistic. We're never going to find a piece of evidence to prove every single thing that we've done. And we've got some great bits of research. I've just highlighted a couple of things there. George Winter in 1962 started this whole wound care revolution off, looking at moist wound healing. His ideas took 20 to 30 years to get into practice before we were able to use modern dressing materials to dress wounds. Brennan and Leeper in 1985 did some research that was groundbreaking at the time and reminded us that strong antiseptics could be harmful to wounds. And then a nurse, Christine Moffat in 1986, did some work from a practical perspective. She couldn't get the right bandages to get rid of her patient's edema, so her and a group of community nurses fiddled around really with different types of bandages until they came upon this 4-layer technique. And the rest is history. We have a principle based on evidence of how to manage venous leg ulceration. But there's lots of gaps in between, and we just have to be realistic. So we will talk a little bit about different types of evidence and where we can use them in the hierarchy of evidence. So I think the evidence is not about dusty old research papers. It's about finding out as quickly as possible what are the new evidence trends, what looks like it's working for patients. It's about accurate diagnosis for the patient. It's about looking at and evaluating the different types of treatment. And often we have done things the same way for the last 10 or 15 years. So sometimes we're stuck in a rut and we don't like to change. So it's constantly scanning, and that's the type of thing you might do when you go to a conference, is seeing where the new studies are and what people are talking about and what they're thinking about. But it's also about referring the patient in to help to the rest of the multidisciplinary team as well. It's not just about treatment. Now, we do have evidence, and some of that evidence is a little bit depressing. So I've got two studies here, a study by Guest and a study by Dowsett and Taylor, a couple of years old now, but basically they tell us in venous leg ulcers, things aren't so good. We've got all this evidence, all this interest, all these specialists, we have multidisciplinary teams, but only about 53%, about half the patients with venous leg ulcers will be healed within 12 months. And those studies are done in the UK. The average healing time is around about 200 days, and about 30% of these patients don't have a differential diagnosis. So we're often slow to diagnose, slow to make decisions, and slow to treat the wounds. So I could go on quoting statistic after statistic, and I think if you're interested, these two papers, and we can let you have the references later, are very, very useful and give you a snapshot of where we are, certainly in Northern Europe. But the problem is, even if we've got good evidence to say compression bandaging is needed, debridement of diabetic foot ulcers is needed, there's still lots of reasons why evidence isn't applied to practice. And we don't like to talk about these issues, but we know in wound care that there might not be much evidence, or it's not what we call strong, robust evidence. So we might say that it lacks credibility. The problem is that there's a lot of healthcare professionals out there, even senior professionals, that find it difficult to critically evaluate studies. We might have the skills, but we might be too busy to do that. We might lack confidence in doing that. And I know with my student groups, we spend a lot of time talking about these issues and how to help people improve their confidence. And that's what this session is partly about. So how can we make evidence-based treatment decisions? We're going to, in the next slide, we're going to start looking at the theoretical literature, and this is where people, you know, as practitioners, you may feel that you haven't got time to do this, but I notice that a lot of people even find it difficult when they're confronted with a piece of research. they might not even know if this is a piece of research or is it an opinion of somebody like myself. That isn't research. So you need to actually be able to decide whether it's research or an opinion of a key opinion leader. Perhaps this information is product literature that comes from a manufacturer and it's not supported by research. And so there's lots of different types of publications, lots of different types of research, and you haven't got time all the time to go through that carefully. So we've got to remember that most people need a bit of help with their critical appraisal skills. And I've just downloaded, these are a few journals that I've sort of got in my office. You know, you'll be the same. You have access to all these journals. You don't have time to read them all, but we have to remember that not all of them are research studies. And in a typical publication like this, you will get maybe 3 or 4 research studies. We need to look at the abstract, and you need to notice and focus on what you're reading. So that sometimes it is an opinion piece, it might be an editorial or just guidance that you're picking up, or practical information about wounds. So not all of these publications will publish research, and you need to be able to make a judgment about what to read and what not to read, because you can't read everything. So it sounds obvious, but if you're looking at a research paper, if it's well written and if it's in a credible journal, it'll have a title and abstract. The abstract will give you the basic detail. What did the researchers do? What did they find? And what did they conclude? And I will usually read an abstract, and I often won't carry on reading any further. If I notice that the sample size is too small or the design of the study is not how it should be, I won't waste my time reading further. But what you see on this slide is really not all studies. It depends on the design of the study, but not all studies look like this. But there's a general guidance. If you can see this information in a study, in a publication, you should be fairly certain that this is a research study. Now, whether it's a good study or not, that's a different question, and we'll come on to that in a moment. When you're looking at research, you do need to look at the year it was published. And you need to remember, if you're reading something from 2000, the year 2000, that an awful lot has happened since then. The way your services are organised may well be different, but treatments are very different. What products were around then? What was standard practice in 2000? If you're looking at a study in 2015, perhaps you're looking at a systematic review of the literature, and I'll explain what one of those is in a moment. But if you're looking at a review of the literature, then don't expect to find recently published studies if that study was only published in 2015, because it can't possibly know what was going to come in 2018 or 2020. So the year something is published is important. You need to also notice the country it was published in. I work in a National Health Service in London, and we have a particular reimbursement system. You may work in an area where your reimbursement system is similar to the NHS, or maybe you're more similar to a North American reimbursement system. So I wouldn't focus a lot on studies about cost effectiveness that come out of America, because it doesn't relate very well to my National Health Service that I work in. So that's all important. And the context of the care, if it's a community study, is it a hospital study? Is it an intensive care study? Is it a study in A&E? All of that will have clinical relevance. So, you know, don't just think about the study and the stats and the findings. Think about what is the relevance to my clinical practice. And this brings me to an important point, is that not everything we read is equal. Not all studies are equal. There are good studies and there are studies that have limitations. So some sources of evidence are stronger than others. And this is where the triangle, the hierarchy of research design becomes important. And I will take a few minutes to explain that to you, because we need to understand a little bit about the different types of studies that are conducted, when they are useful and when they're not useful. And I'm going to go through that with you in a moment. So here is, and I'm sure that most of you have seen this triangle, we call it the evidence pyramid, the hierarchy of evidence pyramid or triangle. And if you look at this closely, sometimes you may get confused, because sometimes you see different types of studies at the peak of the triangle. Today, in 2020, we generally recognise that the strongest type of evidence for making treatment decisions about is the systematic review, or a systematic review that contains something called a meta-analysis. And this is a review, it's a research method in its own right, where the researchers have searched the literature for you and they've critically appraised all the studies they've found. So they've summarised all the studies they've found, and they've written up that summary in a systematic review. Now that's why that appears at the top, because somebody quite honestly has done the hard work for you. So the people that do this type of study are often academics working in universities or in research departments, and they use a particular approach to do this. Now, the randomized control trial, which we all know in terms of treatment, clinical treatment of patients, is a very strong type of study, comes second only because, rather than me read 40 randomized control trials and in my head summarize what they all say, it would be much quicker and more effective to read an academic who had already published a systematic review about the type of treatment that I've looked at. So a systematic review is always higher in the triangle than a double-blind randomized controlled trial. Now I'm going to go through and explain what some of these studies mean, because they're used a lot in wound care. But before I do that, I want to point out that the bottom of the triangle, and sometimes people are surprised when they see evidence-based clinical guidelines, best practice statements, and expert opinion at the bottom. That doesn't mean the opinion of experts are a waste of time. It means that the opinion of experts are just the opinion. They're an opinion of a group of people working in wound care who hopefully have a lot of experience and knowledge. Those people should come from a variety of multidisciplinary backgrounds. They should come from a variety of countries. They should work in the community and hospital, so that they can pool their experience to write best practice statements and clinical guidelines. Now, but what these people do, or these groups do, is they should use evidence to support their opinions. And we tend to use experts when there are gaps in the evidence. And I've already said to you, there's quite a lot of gaps in the wound care evidence. So people are surprised that that's at the bottom of the triangle. It is in terms of research. The systematic review is at the top because it's a very filtered type of research. And I'll explain that in a moment. We'll have the next slide. So I hope this diagram sort of can try and explain what a systematic review is. So these researchers in their academic departments, think of a research question, which might be, you know, what is the best type of dressing to heal venous leg ulcers? And then they will look at, across the global literature. They will have specific entry criteria, and they will filter out any research paper that doesn't meet their exacting criteria. So they might want the patients to be a certain age, they might want the patients to have venous leg ulcers, not mixed etiology, they might filter out diabetic foot ulcers because they're not the same client group as venous leg ulcers. So it's very important that the people making the decisions know about the topic areas, so that in wound care that these are academics with a clinical background so that they can make their specific entry criteria. Once they do that, they search the worldwide literature. It can take several years to do this, and then they analyse each of those studies using a particular and very rigorous systematic process. And they use statistical methods then to join the results together. So they're pooling the results of the evidence and then summarising all of that information for you. Now, the good news is there's quite a lot of systematic reviews in both dermatology and wound management now. They're getting more and more common. So if you find a systematic review about the topic area that you're interested in, then that's like gold dust. You want to read that first before reading an individual study, because hopefully that review has already included your individual study. And the statistical test that they do to join the results, so you could have 10 studies with 10 patients. If they were all conducted in a similar way, they can use a statistical test to amalgamate the results to get a bigger finding, if you like. And that's what we understand by meta-analysis. So everything goes into a filter, and this panel of experts spend time interpreting the studies and writing a report that makes clinical recommendations. And these types of publication often are what inform our clinical guidelines. So if we've got international diabetic foot management guidelines, they're usually underpinned by an international systematic review. So that's what a systematic review is. We're now going to go on and look at a randomized controlled trial. And this is hugely important when we're making a treatment decision. What we want to know is treatment A better than treatment B for a particular group of patients. And let's stay with our venous leg ulcer patients. So here, this little diagram shows you what is the standard design. And when you're reading an RCT, you want to read the details in the abstract to make sure that this pattern of research design has happened. So for example, if you take 20 patients into your RCT, that would be a very small RCT. If you take 20 patients or 200 patients, you'd split them into two groups. You'd have 100 patients in one group, 100 patients in another. And you design your study so that the care of the two groups is exactly the same apart from the treatment intervention. So let's say, for example, we were looking at the effectiveness of a dressing. You would actually put a dressing onto the treatment group, and in the control group, you would ideally have a placebo dressing, and that's very difficult to achieve in wound management, but you'd have a placebo against the active treatment. And the idea would be if the patients were identical, which is difficult in a study like this, but if the patients were identical in immune response and size of wound, etc., then whatever findings you get after a period of time, then it's attributed to the active treatment group, because theoretically the only thing different between the control group and the treatment group is the dressing that you've been investigating. And what you're trying to do here is minimize bias, minimize results happening by chance. And what is very important, and where randomized, the word randomized comes from, is when you split the patients into two groups, you don't just say all the men go into one group, all the women go into another. That would be bias, because there could be other factors at play here. What you do is you make sure that the subjects are randomized. We do this with computers these days, and a computer gives us a number and says this one's in that group, that one's in that group. And we often, with 200 patients, you might end up with a few more in one group and a few less in another. It's not exactly 50-50 because it is randomized, okay? So have a look. The first thing I look at with a study that's randomized, I quickly read it and I see whether I can see a paragraph telling me how they randomised. And it might just say this was computer-generated numbers to randomise the patients into 2 groups. That's all I'm looking for. Now, a lot of our studies in wound care are not randomised, because to randomise takes a lot of time, a lot of effort and a lot of money, if I'm absolutely honest. So the next slide shows us what is a typical dressing study, a non-comparative or uncontrolled study. So this is the next layer down in the hierarchy. It's not as strong in terms of evidence, because this time I've not split them into 2 groups. I've taken my group of venous leg ulcer patients and I've performed a treatment. It might be a bandage, or I might have put a dressing on for a period of time, and then I follow them up. Then I take outcome measures. I might measure the wound or the exudate level or infection rates or whatever it is I'm looking at. And I will then assume that whatever has happened after the treatment of that dressing or bandage is attributed just to that treatment. But I've got no comparison, and I can't do a comparison with people who didn't have that treatment. And most of our wound treatment studies fall into this group. So this is not as strong in terms of evidence. So if the conclusion says, so in conclusion, this dressing is fantastic at healing venous leg ulcers, further work still needs to be done because we've not controlled it. So that's the next level of evidence. And then we move a little bit down. The other key area we look at in the evidence triangle are clinical guidelines. So I've already talked about systematic reviews. So these academic reviews have been done. They tell us that there's a trend, which might be to use compression or debride diabetic foot ulceration. So we start to notice there's a big change happening, and that change, that evidence may be now different to what clinical practice is. So what usually happens is we get consensus groups of experts. They might be from the World Union or UMA, or they might be at national level in your country. And those people sit down and they look at this evidence. So, and from that, they produce what we call clinical practice guidelines. Now, we have to be clear that these are only useful to us if they're based on evidence. 20, 30 years ago, we used to get a group of people in a hospital sitting around a table, writing a document that was my view of how something should be done. And I'd write it. I might not even show it to anybody, but I'm the boss, so I publish it. I send it around the hospital and I say, this is our local guidelines telling you what to do with this type of wound. And in those days, there was no evidence base at all. It was just me telling you what to do, because that's what perhaps I've done for the last 30 years. If you look at consensus guidelines today, and the very first thing I do is I look towards the back of them, you usually find large tables with the evidence. It's got the study name, it tells you how many patients were involved, what type of study was involved, it gives you a little summary of the findings. And these tables can run into pages and pages. And that's what gives you the confidence when you're looking at the recommendations in these guidelines, that these guidelines are based on evidence rather than a group of people's opinion. Because experts' opinion is actually no more relevant than your opinion. So make sure that you're not looking at local guidelines, or if you are looking at local guidelines in your hospital or community, that those guidelines link in with national, international and evidence-based guidelines. That's a really, really important point. So if we move on, an example I can give you from the UK, and apologies, you may not be familiar with, we have a government department called NICE, and that stands for National Institute for Healthcare Excellence. And what this group does, how we produce our clinical guidance for the NHS, is we take an area of practice and we get a group of experts together, or the government does. They bring a group of experts together and they get them to, first of all, spend 6 months or possibly up to a year looking at the evidence. So they do literature reviews, they find systematic reviews, and they end up with a big pile of information on a table, and they sit down and they start to talk about it and start to look at what can we summarize out of this evidence to create clinical practice guidelines. Now, I've got a colleague of mine in dermatology at the minute, they're working on acne guidelines for dermatology, and they've been working on that for over a year, and she thinks it probably will be another year before the clinical guidelines from NICE are published. Now, when they are published, because there's a very robust approach, it's evidence-based, to be on the expert panel, you have to be sort of interviewed, you have to meet certain criteria. And also on the panel are patients and lay carers. So it's not just a group of clinicians or scientists, it's got lay people and patients as well. And if the patient says that guideline, that recommendation is not workable for me as a patient, then it won't go in. So something like NICE, and you can read about NICE on the internet, and I'm sure in your own countries you have similar approaches, put out national level evidence-based guidelines, and we base our NHS practice on evidence-based practice, and it allows us to focus on things that are effective rather than things that the evidence hasn't proven that yet. So we'll move on. Now, what's important, and our next speaker, Emilio, is going to talk to you in a bit more detail about some studies that Ergo have done looking at treatment of venous leg ulcers and diabetic foot ulcers. Those studies have been evaluated by NICE and have been incorporated into their evidence-based guidelines. And you know, that I think really is an endorsement about the level of quality of these studies. So that'll be a bit more detail on that after I finish this session. So back to the evidence triangle, and I said earlier that it is very difficult to find the highest level of evidence in wound care. Now, I'm really pleased to take part in this presentation today because Ergo have spent a lot of time over the last sort of 10 years designing and publishing evidence-based studies at the highest quality, and Emilio is going to talk to you about one of them that was published in the Lancet. And as far as I'm aware, the Lancet has never ever published a wound care study before because it's never thought they were of high enough quality. So I'm sure if you're interested, the references are here. You can see the types of study they are. So if you're interested in any of this data, you will be able to get that from Ergo after the session has finished. So those studies are at the top of the triangle. So I think it's important. I don't think you need to know a massive amount of detail about the research methodology, but you do need to know what a systematic review is. You do need to know what a randomized controlled trial is. You do need to know what a non-comparative trial is, and you do need to understand where case studies come in and evidence-based practice guidelines. And they're all used for different things, but you've got to critically appraise, and you should never just believe or accept something because it's appeared in the published press. So it's very important that you use appraisal checklists, and we haven't got time today to talk about that. Maybe that's a session for another time. So I'm just going to move on, because the questions you should ask are relevant really to the science and the clinical practice. So ask yourself, when you're listening to somebody talk about a study, what are the patients, where do they come from, what are the entry criteria, what was standard care, how long was follow-up, what were the results, and I don't even worry about the results till I've got the information about the study design. So we need to make sure that those things are right beforehand. Next slide. And the last thing we need to do is to apply those results back to the individual. So when you're reading the results, ask yourself, what does this mean for my individual patients or my groups of venous leg ulcer patients or diabetic patients? How can I implement? Is there anything I can improve? Does this study tell me anything? And it may not just be about using a particular dressing. It might be about implementing getting a diagnosis and implementing a treatment earlier. And can you explain that to the patient? You know, we need to involve the patient in this clinical decision making as well. So just to recap, and just to 1 minute to just sort of come to the end of this session, there's a lot of barriers to the implementation of evidence-based care, not just poorly designed studies, but we might not have the time or the skills to understand those studies. Sometimes we're not taking those results and thinking about what we need to implement today. So there's a time lag always between research findings, and it can be as long as 20 years. So we need to get smarter at reading and then thinking about how this affects our patients. Next slide. And so it's looking at treatment pathways. These things should always be underpinned by the research evidence. And if we just go to the next slide, please. A treatment pathway like this, you're familiar with those. You need to actually understand where all of those elements of that pathway come in and where they're supported by evidence. And if you can't see that within that pathway, then you need to ask questions. But we do have a growing body of evidence. We do really understand now chronic wound management. What we've got to do as experts is encourage everybody else to implement that treatment, because we can do better for our patients right now. Next slide. And so it's being confident in your critical appraisal skills. It's about reading good quality and going to the internet sources that are better quality. It's about discussing it with your multidisciplinary team and planning how you're going to make changes. And again, you might need to look at your local guidelines. Do your local guidelines reflect current evidence-based practice guidelines? Next slide. So, and I think I'll finish here on this slide. We saw this slide earlier. Evidence is not just about research findings and studies. It's about everyday clinical practice, and it's about making a real difference to the patients. There's no point in us finding out that there's an effective treatment if it takes 20 years for that treatment to get onto your patients. So I think my take-home message really from today is have the confidence to look at studies, have the confidence to talk about them within your multidisciplinary teams, and have the confidence to make changes and explain to your patients why, you know, the treatment regimes that we have are moving on all the time, but only make changes if you've got a confidence in that evidence base. So I'll stop now. My time is done, and just before I hand over, I've just put my email address there. If anybody, I know there are some people in the audience who are perhaps interested in joining me with some of my master's programs. If you are at all interested or have any questions about anything I've raised, please email me on m.flanagan@hearts.ac.uk, and I'd be really pleased to hear from you. And I'm really thrilled that our next speaker, Emilio, is an ex-alumni. He's a student of mine a few years ago, graduated probably 5 years ago now, I think, Emilio.
Yeah, we were the first group from the Middle East, myself, Gulnaz, and Yusuf.
That's right. So, you know, it's fantastic to see, or you being able to invite me to speak and then me passing on to you as a speaker. So thank you very much for that opportunity.
Thank you. The pleasure is definitely all mine. And before I go to the slide deck, which is quite short, don't worry about it. It all started actually in a conference that we had invited you to Dubai, if you remember. I was actually doing an MBA, and I told you I hate it because I hate doing business. And you told me, why don't you do wound care? And voila, that it all happened.
Right.
And what I tell the attendees is go for it. It opened so many doors for me, and definitely if the person in the next slide next to me wasn't there for me, I wouldn't definitely be here today. So I thank you in front of all the audience for all the support that you gave us. And it was fun. It was really, really fun. So please, guys, don't be scared. It will be fun. Go for it.
Thank you.
No worries. So we'll start sharing.
Yeah, Emilio, just before you start, just remind, you know, we will answer the questions briefly after your part, okay? Because I can see a few questions, so we will answer them in a few minutes. So.
Yeah, thank you very much. So basically, what I'm gonna do now is build on all the discussions that Madeline had before me, and seeing how that can relate to what we are doing. So that is why we called it evidence in practice. I like to use this slide, and probably you saw me using it before, where when you're opening a dressing, it has to show you three things. It does what it says on the box, improves our patients' life, make them lives much better, and basically the health economics, which is the cost effectiveness. How do we know this? We know this basically from all the evidence that we can get. And from our side, we are very proud that we build what we say on evidence. One of the unspoken policies in Urgo Medical is that we cannot say anything if we can't claim it, and not just claim it because we think it is. We claim it because it is based on robust evidence that we talked about before. And you see that there's a lot of studies there, and these numbers are not entirely up to date, but gives you an idea of how much time and effort we put in providing evidence for clinicians to talk about. And we'll see that clinicians all over the world, all the high-level clinicians all over the world are talking about Urgo Medical because of the evidence we produce. So we talked about the top part of the hierarchy, and this was a systemic review that has been recently published on the Journal of Wound Care, where Desimond and a group of his colleagues did a systemic review on MMP inhibiting wound dressings. And it's a very interesting read. Well, the first interesting thing about it is they actually talked about what is the difference between MMP inhibitor and MMP modulator. And when they started doing their systemic review, they started looking at a lot of different dressings, and they started excluding. And one of the things they started excluding is the foam dressing and other types of dressings that say that they reduce MMPs because they wake up the exudate. Well, that's not an effective way of doing it. So they ended up with a systemic, in their systemic review, that they only found 2 dressings that had robust or good evidence, with the TLC and OSF or Urgostart having the highest level of evidence against collagen ORC dressing that had only low to medium type of evidence. So what they are suggesting is that these wounds, which are the chronic wounds, it is highly recommended to use TLC and OSF or Urgostart. Another nice systemic review that has just been published is about effectiveness of healing in chronic diabetic foot ulcers. And again, they looked at all the evidence, and they found that one of the robust evidence that we'll talk about later on, which is the Explorer study, again talking about this dressing, which is called Urgostart. And as we did mention before, loads and loads of randomized controlled trials. Very nice randomized controlled trials starting from 2004 about the first dressing, which was called Urgotul, building up to the latest studies. One, we don't have time to read them all. Two, probably we don't have them all because most of them you have to pay and they're not cheap. So this is where we come in, and what we do is something that we learned about, which is called replication. So what I do from my side is, you know what, I work in Australia, Asia, South Africa, Middle East. And one of the questions that people ask is, yeah, they did the study in France, Germany, whatever. Will it work in Vietnam? And this is what I do. We collect case studies from the region, put them together and publish them. So like, for example, next publication is going to be on the Wounds Australia Journal about combination actually of two treatments, which is compression bandaging, Urgo-K2, and a dressing, which this last, which is Urgo-Clean. And we have a couple of cases from Singapore, actually. Another thing that we do a lot as well is observational study. And this is one of the latest that has been published with over 2,000 patients using a dressing called Urgo-Clean, which is an antibiofilm on desloughing agent. And the outcomes, as we see, are all good. And one of the things that you see here, these are mostly the primary objectives. And what we look also as well, even if you look at the RCTs especially, apart from the primary objective, which is usually the wound area reduction, you have the secondary objective, health-related quality of life, cost effectiveness. How is it that the clinicians are finding the dressing? Is it easy? Is it difficult? So even in these observational studies, they publish that as well. And I'm very happy that Urgo actually publishes post-hoc analysis usually about even these secondary measures and talking a lot about that. Long story short, trying to go faster, this is again another type of study that was published, which is, it was called the reality study because they wanted to see what is really happening in real life data. And what they did is they compared the group of patients that were being treated, all the patients that were being treated according to observational studies with Urgostar, comparing to the rest of the country. And what they found out is that reduction of the wound area was actually quite remarkable when you use Urgostar. But then they published what is called the post-hoc analysis. And this is where they found that actually the earlier you used to use the treatment, which is first-line management, the better the result. And this study was already mentioned by Madeline. This is it's the flagship, if we may say. It's a first in many things. First double-blind study. We can get away with it because the two dressings, which is Urgotul and Urgostar, look the same, feel the same, smell the same. You can't ever take a difference. So this was one of the main things why actually the Lancet accepted it, because it removes a lot of bias from there. Another first was it was on neuroischemic diabetic foot ulcers. Nothing was published on that before. And again, what is really interesting is that different studies done on the treatment, which is the Explorer, the Reality, and there's other studies like the Challenge study, all had almost the same results. So this gives you a replication in different RCTs. What is important is the reaction of the study. I remember our president saying that as soon as the Explorer was published, he got a call from Reuters from the US in a few hours asking for what is this study. Then it was all going on and on. We had Spain, France, NICA, as we said, we had the Journal of Wound Care Award. But notably, it was the IWGDF, the International Working Group of the Diabetic Foot, who suggested that TLC and OSF or Urgostar should be used on these diabetic foot patients. So I would like to close with a quote. I really like this quote from John Adams, which is one of the founding fathers of the US, where he is basically telling us that it is not what we think is best. It is what the facts tell us which is best. And basically, this is what evidence-based practice is. Go out there, find what the evidence is saying, and then we see how we can implement into practice for the benefit of our patients. Thank you very much. That is all from my side. So I think we're almost bang on time, Madeline.
Yes, yes. There may be some questions or comments.
Yeah. So, do you want me to read the questions or you? I mean, I can see a lot of regards, welcoming many fans here in the region and outside
your
region.
fan base, Madeline.
Yeah,
it's all your fan base.
I've had a little look at the participants' questions, and I've just made a few notes, and it's absolutely lovely. I can recognise people, and apologies if I've missed anybody out. I can recognise people who are current students, past students, and people who are going to join me hopefully in October. There's people from Saudi, there's Bahrain, the South Africans are with us this evening, UAE, Qatar. You know, it's lovely. Kuwait, to see people in all of those countries. You know, and I think it reminds me that we are a community. We're a community at the minute that perhaps can't speak to each other, but I think, you know, using technology like this, you know, we can adapt, and it's not the same as being face to face, but it's really important that I think we can, you know, virtually hold hands and share experiences, because of course we should have met already at the World Union Conference in Abu Dhabi. We're still hoping that can happen, but we're in a very difficult situation. So, you know, it's just fantastic to see everybody here. Are there any questions, specific research questions, or that anybody wants to raise?
I think, yeah, mainly welcoming. They're asking if you have any publishing books coming out, not related to the.
Yes, no, I've not written a book. Writing a book takes about 2 years. So I haven't got a book coming out, I'm afraid. So no, but you know, I do still publish in the journals.
I have a question related to what was explained, maybe about the clinical expert guidelines at the bottom of the evidence base. I mean, is it? I mean, in my opinion, any expert guidelines should be based on evidence-based, like reviewing publications or studies. But they can they publish any guidelines without doing that?
Yes, and this is the problem. You know, we all know the problem with the internet is that you can have your own web page or blog or whatever, and you can say whatever your views are. I'm afraid to say that I have seen recently in the last 18 months to 2 years, published in the UK by fairly reputable publishers. I have seen some best practice guidelines written about venous leg ulcers. And when I looked at those, it was one of my students that brought them into class and said, I don't think these are very good. Can we critique these guidelines? And we looked at the guidelines, and, you know, there were various issues. First of all, the group of people, you don't want a group of doctors or a group of nurses. You know, if it's venous leg ulcer, you need vascular people. You know, you need the whole representative of the multidisciplinary team. You need different perspectives, but you also need those guidelines to look at the global evidence. And what this particular document, it had picked, and we can all do this, I could pick any evidence to support any argument that I had by just randomly picking the things that support what I believe in.
Yeah, exactly.
And it can be very difficult. This shouldn't happen, but you do sometimes see where groups have got together and they've not been very selective. And one thing that, you know, became obvious is sometimes you find there's 10 people in a group, and when you look at the evidence is just the studies that those people have published. Now that can't be just the evidence that there is out there. So I think it's difficult for people when you're reading, you think everything that's published is of the highest quality and it's been checked before, and that should be the case. But mistakes do happen, things do get through, and you need to be careful. You need, if you look at guidelines, the first thing I do is I look at who wrote them, and I look who's there. And because we're a small community, we know each other. So, you know, has it got people from the Southern Hemisphere and the Northern Hemisphere? Has it got doctors? Has it got podiatrists? Has it got vascular surgeons? You know who it should have. So are they the right people? Are they from the right background? And they, if they are, have they looked at the systematic reviews that are out there? And they need to look at things like Cochrane reviews, you know, NICE reviews, and independently sourced systematic reviews. And there may not be a systematic review that supports the view. They may need to look at individual randomized control trials. And if randomized control trials aren't available, then they drop down a level and they look at non-randomized control trials. But they need to be transparent about what they're looking at. So not all, I said at the beginning, not all evidence is the same, and it's the same with clinical guidelines. It can look good. Often things look very professional, but there's not much substance in them. So you have to be careful.
Yeah. So
if I may, excuse me, if I may join in to that as well. There are guidelines and there are guidelines. There are guidelines like NICE, there are guidelines like IWGDF, but there are guidelines, clinical practice guidelines that tells you, you know what, the bandage ABC is recommended the best. And then you go on the second page and you see sponsored by ABC company. So I think you have to look at the bias as well, right?
You do, because that's a bias. You know, if a company makes a particular type of dressing and the only dressing the guideline recommends is the dressing they produce, then, you know, as clinicians, you have to have your clinical hat. It's not a research hat there, it's a clinical hat where you say, well, this isn't right, you know, and guidelines that I've read have done just that. They've recommended alternative methods of compression bandaging, like wraps, and totally discarded the literature on compression bandaging. Well, you can't do that. You need to look at everything, and you need to make a research and scientific based judgment. And you also need to make sure that it's not me and you writing guidelines to tell the hospital what to do. We see a lot of that as well. That's not evidence-based either.
I think there's a couple of questions about DFE which I can quickly get through. One question was, what type of wound bed can it be applied to soft tissue? No, you should debride first. Because it will get you better results, because remember, Urgostart is there to help the granulation. There's a couple of questions, very good questions about NICE. One of the questions which I think is very nice by Anonymous is, do you know how NICE evaluate these studies? What is the important for them to get approval?
Yes, they look at two things. They look at clinical efficacy. So in other words, does it work? If it's a dressing, does it debride or does it produce granulation tissue? If it's a painkiller, does it reduce pain? But they look at clinical effectiveness, and the other thing they look at is cost effectiveness. So I forgot to sort of say that, because this is a government guideline, it wants the most effective management for patients and the most cost effective. So it looks at cost effective and clinical efficacy. And so it looks at cost economic studies and does a sort of an economic evaluation, and it looks at clinical efficacy. It puts the two together with this group which has doctors, nurses, etc., plus patients. And I think that's what's important, is it also has the patients and the lay carers, and everybody has to agree. And those guidelines are reviewed every 2 or 3 years. They're often controversial, so sometimes they come out, and there was one a few years ago where it did not approve a particular treatment for breast cancer, and a lot of breast cancer patients were devastated and felt this was wrong. There was a lot of protests, but in fact there wasn't a large body of evidence. And then 18 months later they reviewed it again. There were some now big studies. Those studies were joined together with the other studies, and the guidance changed and said this treatment now has an evidence and cost-effective base. Yeah. So, sometimes we don't like the guidance that we get, and we have to hope and wait for more evidence to come through, if you like. But I think, we've just got to get used to, we can't do what we want to, in the past, people have just done what they've always done. Particularly some members of the team have always said, I've done it this way for 30 years and that's the way it is. And patients have a right to the most effective treatment. So we can't take that approach anymore. So we might have to reappraise what we're doing, and it can be uncomfortable. Yeah.
From our side, our medical director, Serge Bobo, after I met him after the NICE publication, he told me in his very strong French accent, he told me, you know what, the nice people are not very nice. Yeah. because he told me there was about 32 people in front of them asking questions. But he told me it was very, very, very difficult, even though the evidence was there, to convince them about the robustness, and you have to prove it very, very strongly before they put it on a guideline. It's a very
high-level critical appraisal, so that if they do recognise that findings of studies are valid, and they do give that recommendation, then that's a big endorsement for the quality of the work that's been done. And I think it's, people forget that to conduct clinical research takes a huge amount of expertise, time, logistics, and to do a randomized control trial costs thousands and thousands of dollars. I have no idea the big cost.
I can tell you exactly about the Explorer. It took 5 years of cases, 7 years to complete, and 7 million euros.
7 million euros. Well, that's more expensive than I can afford.
Exactly. That is why many people tell us, why don't we do an RCT? Right. Statisticians, auditors, it's not easy. And that is why probably, and you might agree or not, is that probably these observational studies are easier to do, even though it takes a lot of effort, like we saw the one from Germany. But you can complete it in a much shorter time because it's a non-interventional study. Yeah. So, and it's quite valid as well.
Which is why you won't find an RCT to prove everything. You couldn't possibly find an RCT to prove everything. So, and that's why case studies, case studies are valid. If I want to show a clever way of bagging a wound or dealing with a sinus, that's where I would take pictures. It's not research per se, but it's a very valuable tool to clinical practice to show what I've done, and maybe you can do that in South Africa or wherever you are. So the problem with the triangle, it does give the impression that the things at the bottom are not worth anything. They are in particular circumstances.
Yeah, especially the case studies, as I said before, where we replicate actually what was being done in our city, in Europe, and somewhere else.
Yes.
I think if we keep on talking, Madeline will be here till
I
tomorrow
know,
morning. Maher, can you maybe take a note of some of the questions? Is it possible? We will see from the recording, yeah? And then we maybe can answer later.
If we've not answered a question, we can get back to you afterwards, yes.
Yeah, I can do that. Yeah, so because we still have many questions coming, and I think each question needs around 15 minutes to discuss. I mean, but I mean, just maybe one short question for one short answer, which is really a good question. When do you think evidence-based practice could be valid or not in your clinical, like after many years, or it's not valid anymore? This is the question. What is the number of years? Like something was published in 2008, 2010,
oh, I see.
we are 2020, so
it's that's a very good question. It's a very difficult question. I suppose really the answer is when something else new of a high quality has been found out. So, for example, you know, we talk about George Winter in 1962. That's nearly 60 years ago now. And there's been lots of other research since then. But sometimes something is classic. It's the first time it's been done, so it's important. But it's absolutely right. If you were looking at a treatment, a bandage, a dressing, a drug, and you were looking back to something in 2000, so in 2000 this was the best thing there was, and that was the evidence base at the time. That's what I meant in that slide where I said look at the year of publication, look at the context of the publication. Really, any treatments that are way over 10 years old are going to be superseded. You know, they're going to be superseded just from technological advances that have been made. So it depends what the research is about. If it was about the experience of diabetic foot patients, the experience they have with their wound and quality of life, that study from 2000 would be still valid because people's experiences haven't changed. Do you see the point I'm making? But if it was looking at a foam dressing, then the technology and the advances that have been made since then would mean that probably that treatment, you know, it would be irrelevant to look at that treatment. So it depends what you're looking at. So you've always got to try and make sure that what you're searching for is up to date. Start now and go backwards. Don't start 30 years ago and go forwards. You need to look at the evidence base.
Yeah. Like one of the studies that I mentioned was about Urgotul, which is called the MAP study, which is now almost 20 years old. But what they talked about was seeing if the dressing was atraumatic or not. So if the dressing was atraumatic, it is still atraumatic.
Yes.
It's not saying that, you know, this is the best treatment. It is.
No.
So it depends on what they want to prove, I guess. Yeah.
Yeah, that's. I think we can try to answer the other questions by email. I will send them to you and Madeline and see what can be done. So again, for the sake of time, I mean, it's our pleasure to have you for another hour, but it's already 11 here in UAE. Thank you so much for an amazing lecture, very informative, and actually can give us a little bit of the light behind the tunnel, you know, to see which evidence we can spend time to read, because as you said, we cannot really read everything. And honestly, there is a lot of published things, let's call published papers, where you need to differentiate first, is it worth our time or not? Then we read it to be based. Thank you so much.
And I'd just like to thank every participant. Some people have gone, but I can see on my screen There's 159 people at 11 o'clock at night, and some of you it's even later. And I just think that's absolutely fantastic. So, you know, we couldn't do these things without your participation. So if you have got questions or comments, come back to us and we will do our best to follow those up. If you've got some ideas for other seminars like this, maybe along the same themes about looking at the literature or whatever, let us know, because we can always look at those in the future. So thank you for your participation as well.
You're welcome.
Thank you very much, everybody,
Thank you,
and thank you for the service you give to our patients in these difficult times as well.
Yeah. And stay safe all. Thank you so much. Good night.
Bye-bye. Good night.
Thank you. Good night.